Good morning, everyone. My name is Kelly Caseman. I'm the Executive Director of Think Kids, and thanks for joining us for Including All Kids, Transforming the Healthcare System for Children with Special Healthcare Needs in West Virginia Policy Roundtable. I'm going to share some details about the project, some logistics, and then I'll introduce the panelists and we'll get underway. A higher number of children with developmental disabilities are socially and economically disadvantaged, and they may lack the community services or social supports to access needed care. Families are relied upon to provide numerous complex tasks related to the care of their child with periodic support from healthcare institutions and professionals. These are significant challenges to ensure healthcare access for children and families with special needs in our rural, medically underserved state. Families often struggle throughout the process of accessing care, from getting the correct diagnosis, to finding specialty care, to accessing community resources for even the most basic health services. This project is the first step in a journey to working with stakeholders to better understand, give voice to, and prioritize the challenges families have within their respective communities around the state to accessing healthcare. Our goal, with your help, to improve the healthcare system for kids with developmental disabilities. And if you're interested in learning more about the project, visit our website at thinkkidswv.org. You can check out our surveying project results to date, and you can sign up for our stakeholders list. And we're very glad you decided to join us today. And so here's our agenda. We'll begin with introductions of our panel and then jump into some pre-prepared questions. You're welcome to post questions at any time in the Q&A box, and periodically when there's a break in the dialogue, we'll check and see what questions and comments you have to share. Please know that if you think of something after the event, this video will be posted on our YouTube channel. We'll respond to any questions or comments you have there. And so let's begin the conversation by introducing our panelists in alphabetical order. Bill Albert, Director of Legal Aid's Advocacy Project with Legal Aid of West Virginia. Christy Black, Parent and Advocacy Specialist with West Virginia Developmental Disabilities Council. Allison Bungard, who is a parent and partner at the law firm of Dinsmore and Shohl. Dr. Lesley Cottrell, Director of West Virginia University Center for Excellence in Disabilities. Dr. Beth Emrick, I think she may be joining us in a little bit, Associate Professor of Pediatrics and a Developmental-Behavioral Pediatrician at Marshall University. Dr. Jodi Lindsey, Medical Director of West Virginia University Medicine Children's Hospital Neurodevelopmental Center. Pam Rausch, Director of West Virginia Birth to Three, and Steve Wiseman, Executive Director of the West Virginia Developmental Disabilities Council. So thank you all very much for joining us. I feel as if we have an all-star cast today, so I'm excited to get underway. Let's begin with our first question. And panelists, this is just a reminder that you're welcome to answer any questions, but not obligated to answer every question. If we're having a robust discussion and you're not quite sure how to politely jump in, please just raise your hand and we'll get to you before we move on to the next question. For those watching who may not understand how or why the healthcare system is different and more challenging to navigate for families and caregivers of children with developmental disabilities, how would you explain it to them?
I think there are several issues. First of all, we don't have all of the necessary pediatric providers within our state. And then where we do have necessary pediatric providers, they are not necessarily located in the same area. They're spread out throughout the state, and they are not necessarily affiliated with the same hospital. So there's a disconnect between the services that those providers give. In addition, many pediatric specialists may be solo practitioners. Where that can become an issue is with emergencies, because they're not available 100% of the time, and there's not a backup if they're not here. That's also an issue for scheduling. I know we try to schedule things when our son is not in school. So for example, a couple of years ago, he had an eye surgery. He had it on the day that school let out for winter break. And we saw his normal doctor perform the surgery. And then we actually waited in Philadelphia to for the follow-up, and we saw her medical partner because she was off for the week. So there was a backup, who we were able to see so that we could have that done at the same time. In addition, there are transportation issues here. My son has cerebral palsy. He uses a wheelchair, and we have very limited resources in terms of public transportation. And although my husband and I were fortunate enough that we were able to purchase a wheelchair accessible van, many families aren't. So with very little public transportation for people who use wheelchairs, it's difficult for them to get to the doctor. I mean, I know for us, our PT clinic is actually in another county, and like Kanawha Alternate Transit doesn't travel there. So if it weren't for us having that vehicle, we wouldn't be able to get our son to therapy in another county. In addition, I would say that another issue, particularly for our kids who are non-ambulatory, is that West Virginia has a list of non-covered items through Medicaid. That list includes many forms of adaptive equipment, such as standers, gait trainers. These are all necessary things. Standing, part of how we develop through standing is an important, plays an important role in the development of our bodily systems. For example, our digestive systems, our bowel movements are based on us being able to stand. And when you can't stand and you don't have access to a stander, that causes you to become constipated. So like we have a nickname for our son's stander. We call it his poop machine. And because when he's having issues, we can stick him in the stander, and after a little while, it's going to help his digestive system start moving. So it's a big issue that many families can't afford these things. We actually got our stander as a gift from someone who was no longer able to use it. So, and it leads to bone problems. Our son had to have a hip osteotomy. One of the reasons is because he wasn't getting enough standing time during the time frame between birth to 3 and when we got this gift of a stander. It resulted in the dislocation of his hip, and he had to have a hip osteotomy. And that is considered one of the most difficult surgeries to recover from. So that is something we immediately need to address, is getting equipment, more adaptive equipment covered.
And I would, I'm going to try not to, some of my concerns are the same as Allison's. Those are some of the things that actually I would say too, but not to repeat what Allison said. It's like it's a one size fits all system, and it's like putting a square peg in a round hole. That is how I would probably try to explain it to other people. When you have a child with a developmental disability, along comes a comprehensive list of medical diagnosis. And like Allison said, there's not necessarily, we don't have all the specialists, so it's traveling out of town. The other issue is insurance coverage. Most people, in trying to explain it to someone that doesn't have a child with a disability, you go to the doctor, you go to a routine appointment, you pay your copay, then you get a bill in the mail and you pay the other 20% or whatever it is that, your insurance covers. But, for us, a lot of the things, a lot of the treatments or some of the testing isn't on the little flip chart, of CPT codes. So then it is, battling the insurance companies or trying to get the procedure, and you're working a lot of times with the doctor and getting that. For us, there were some specialists we had them in our area, but they didn't accept Medicaid. Our daughter has a primary insurance and Medicaid was the secondary, but we still had to travel out of state for a while until we were able to find someone that would accept Medicaid, or they only accept so many patients with Medicaid. So I think that's a big issue. And that, again, falls back on that non-covered list that Allison mentioned about getting things, covered. So.
Thanks, Christy. Anyone else want to take on that question?
Yeah, I'd like to chime in. So the question was, how would I describe the challenges for families to navigate the system? And I went and I spoke with one of our staff members at Legal Aid who has a child with a developmental disability. And I think the best way that she described it that I will share with everyone is it's a full-time job in addition to what else, your other work obligations that you may have. And trying to fit everything in and trying to juggle everything with all the hoops and barriers that you have to navigate around. So she sent me just a paragraph, and I think it just really describes some of the challenges that we've already heard, but I just thought that I would read it. So she noted that we see doctors at Children's Medical Center, Pediatric Specialists of Virginia, Johns Hopkins, and our local pediatrician. We have billing through private insurance and Medicaid. We get some medications locally and others through special mail order pharmacies. And due to medications, we have to have blood work. These many doctors and medications are just for the day-to-day management of her child's diagnosis. So that doesn't even include annual checkups, the need for a special dentist, for example, and then other concerns that I know we're going to talk here a little bit about, but right now with COVID and wearing masks when masks are required, and then having a medically fragile child. As she noted, it takes so much time. To me, that she's the feeling of exhaustion just packing the car to go to these appointments and loading her child into the vehicle, and then having, most of the time it's not a short drive, it's an hour or more long drive to get to these appointments, and then getting there and having to sit in a waiting room and wait and deal with any behaviors that the child may be having. So that I think is how I would describe some of the challenges. I've noted just some systemic challenges that I've talked about, transportation, and I know we've got some questions about transportation. Just services that are lacking for children that don't have IDD waiver, I think, is another systemic challenge. But then, some of my responses that you'll hear in other questions just relate to the practical problems that families experience. And that those are things like having a little more flexibility with regards to medical appointments and how much of a barrier it is to have to pull a child out of school just to be able to participate in the appointment when it's scheduled during school hours. Things like, we're going to talk about telehealth. And while I feel like it's a good option, some families may not have internet services to access telehealth. Some families may not have enough minutes on their cell phone to call into those types of appointments. So those are just some of the real world practical challenges that I would share with everybody just to describe what it's like.
Thank you, Bill. It's a really important answer. Anyone else want to answer that question before I take to the Q&A box and share some information from there? Okay, well, we've had 3 questions, comments and questions from delegates. The first is from Delegate Mike Pushkin, who said, "Thank you for the invitation. I look forward to learning more about how we can help. He shared his cell phone number, so panelists, please take note of that. And he said, my question is, what legislation is needed in next session? So there's that question. And then Allison, there's a question for you. Is it Modiv Care not arrange for transportation?
Okay, so
Go ahead, Allison, please.
okay, so with regard to the first question, what legislation is needed next session? One of the things that I personally have been advocating for and part of a campaign for is changing spaces. We in West Virginia, none of our hospitals that I'm aware of that we've been to have a powered adult-sized, height adjustable changing table, so that when we go to the doctor, our son is not able to be toileted. And anyone who has been to a hospital or a doctor's office, you know that you have to wait sometimes. You may have to wait between tests, things like that. We have been at the hospital for hours, and there is not a place for us to toilet our son, for us to transfer him onto a table and raise it up. That was one of the things that when Children's Hospital of Philadelphia built their new Burger Center for Advanced Medical Care, they included that on the orthopedic floor, and I believe there's one maybe on the neurology floor. I know there's one on the orthopedic floor, but we use that every time we go because we're usually there for a long period of time. And so our hospitals really need to look at doing that. There are other places in the state I think we need that as well, but since we're focused on healthcare here, our hospitals really need that type of system. We need to look at some, like all of our doctors' offices, none of them have a wheelchair scale so that we can actually weigh our son when we go to medical appointments. So a lot of medications are based on weight. So when you can't take your son's weight, that's a challenging issue. We actually saw a local pediatric endocrinologist and nutritionist to help us with our son's weight management because he uses a wheelchair, he doesn't burn calories the same way that typical kids do. They also didn't have a wheelchair scale. So here we are specifically dealing with a weight management issue, and there's no way to weigh our son. Most doctors' offices also do not have either a lift or a height adjustable table that you can transfer a patient onto and raise it up for doctor care. We often find ourselves having to lift him. He weighs at this point about 145 pounds, lift him onto a high table. And when I'm the only one there, that is a big strain on me to be able to do that. So I think those are some issues, some legislative issues that could be addressed. I also think the issue of covering adaptive equipment, that the legislature really needs to look into that. My understanding is that we are not supposed to have a type of non-covered list through the health check program, but we do, and that list includes gait trainers and standers. And these are harming our inability to access that type of equipment is harming the physical bodies of our children because they do not have access to this type of equipment. That is something that could easily be addressed legislatively, or certainly through the legislature looking at what the Bureau of Medicine has designated as covered and non-covered. So about the transportation issue, will Medicaid cover that? Okay, there is non-emergency medical transportation. In most circumstances, people are going to have to provide their own transportation and then get reimbursed for the cost. One of the issues with that is that you have to do that pretty far in advance. It's not like you can do that, like Andrew can't wake up, be sick today, and me likely schedule non-emergency medical transportation to get him to the doctor's office today. You usually have to do that in advance. For him using a wheelchair, he still requires a wheelchair accessible vehicle. So we still had to provide that for ourselves. I know that that CNH taxi service does have one wheelchair accessible taxi. It is very difficult to book it. I do know that Canal Alternate Transit, we have used that a couple times to get him to therapy, like if our car was in the shop or whatever. But you often have to book that like 2 weeks in advance to be able to use that service. It's often booked up. And so so I guess there are things that, like, theoretically, it sounds like, yeah, you should be able to get transportation, but practically speaking, when you actually try to do it, it's not necessarily available. I mean, I remember one time Canal Alternate Transit told me that for me to send my son and his respite provider to the movies, that I was going to probably have to do that at least a week in advance, before you even know what movies are playing at the movie theater, whether there are any kids' movies actually there. So when you then put that in the concept of medical care, which often happens much more quickly, he wakes up sick, you need to go to the doctor. It's just, it doesn't always happen as nicely or as neatly as it should.
Thank you, Allison. Dr. Lindsey.
Yes, sorry. I think I shut my video off. I'm sorry. So I just wanted to respond to a couple of those things. One of the exciting things, and it's not anywhere near like it needs to be in the state, but actually we do have an adult mechanical adjustable changing table in our clinic here at the Neurodevelopmental Center. So the first one at Children's, I really pushed hard. That was one of my big asks that I thought was absolutely necessary, and in pushing for in the new areas that will be part of Children's Hospital as well. In addition to that, we always have the wheelchair scales, which is ultimately important. We do have that through our subspecialty pediatric clinics. We have it here at our center. But a lot of the outside physicians throughout the state, you're exactly correct, do not. And a lot of the things we're basing it on are in the primary care setting. One example I can give is I actually did a clinic for a while in Fairmont out of a family medicine clinic and held my specialty neurology clinic there. And one of the asks I had for UHC at the time was for them to purchase a wheelchair appropriate scale. And it ended up that the clinic liked it for all of their adult patients, and it was much easier use. So I think if we could start advocating in some of those realms and educating some of these outside providers to the benefits that it would be for all patients around, that kind of helps with some of that. I completely agree with the legislation for approving this DME equipment, such as standers and gait trainers. I can't tell you the number of times we're fighting insurances, and it doesn't matter how many times I appeal Medicaid and our state insurances that my patients absolutely need this equipment, that it is essential to their care. I can't get anywhere with it. And so I think that is an absolute must for legislation.
Thanks, Dr. Lindsey. We have a couple more comments in the Q&A box that I'd like to address. Oh, and I'd like to introduce Dr. Beth Emrick, who has joined us. She is Associate Professor of Pediatrics and a Developmental-Behavioral Pediatrician at Marshall University. So thank you. And I'm sure you're probably seeing patients. So we're glad you have time for us today. This is from Patty. She said logistic care is an issue with the 5-day notice. A problem that could have been fixed with a simple office visit and an antibiotic can turn into an ER visit and a possible hospital stay. Not all doctors will prescribe without seeing the child. So I think that's an important point. And then from Wendy, as a treating pediatric physical therapist in West Virginia for the past 25 years, I see many families whose children would benefit from the items currently on non-covered Medicaid lists in West Virginia. These items were covered by CSHCN years ago. The list includes standards, gait trainers, toileting systems, specialty beds, and activity chairs, to mention a few of the items. Function and participation is important for all children and families. EPSDT reimbursement is cost and less than Medicaid. How can this be fixed? Any panelists have any ideas on how to remedy that?
I think we need to look at the reimbursement rates, actually, because, you know, that's the problem. I know that I've heard even from, I've heard from families even talking about like diapers. The reimbursement rate is so low for adult diapers that it's hard to find a vendor that you know, that has them, because, you know, vendors also have overhead costs. And so if I think I think that is a big issue, is just looking at that non-covered list for different equipment, but also looking at maybe some of the reimbursement rates for different items as well.
Thanks, Christy.
I also think along that lines, working with the insurance coverage, they can obviously do contracts with various companies, or for instance, hospitals are now doing these group purchasing orders. It's becoming more and more common for equipment, which significantly lowers the costs. That's one of insurance arguments, is that these DME costs are extremely high for some of the equipment, right? And so if negotiations could be made that also with certain companies lowers the overall cost for insurances, then we correct and kind of meet in the middle between improving reimbursement cost and dropping the cost overall to the insurances. I think between the middle, we should be able to do that.
That's a great point. Thank you. Are we ready to move on to question 2? Okay, let's address some of the biggest challenges to accessing healthcare first, and we'd like for you to respond in either 2 ways or both ways. Help us contextualize the problem, perhaps discuss how to address the challenges with a federal, state, or specific system solution. So let's begin with the lack of healthcare providers. We've heard repeatedly throughout this project that there's a workforce problem on a few different levels. There's a lack of primary care providers in West Virginia who are trained to care for patients with special healthcare needs and have the accessibility and equipment to accommodate them. There's also a lack of specialty care providers in the state. And when there are providers, there are often long wait lists. What's being done and what can be done?
I'll start on this one. So obviously being in a field that is one of those areas that is a high need. So both child development and pediatric neurology. For instance, when I came back initially to practice in the state about 10 years ago, here at the university, I was one of 2.5 practicing child neurologists. And that at the time there were 2 others spread in other areas of the state doing limited care. We have now grown dramatically, but still not to the point that's necessary for that critical mass. An example is our group here for pediatric neurology is now up to 9 of us pediatric neurologists at WVU Children's. And then there are multiple others in the state, currently 3, I believe, practicing pediatric neurologists outside of WVU Children's. For developmental behavioral pediatrics, Dr. Emrick knows well. Her and I, for a long time, were the 2 in the state evaluating and seeing these children, which makes for very long waits, especially when you're talking our new visit evals can take anywhere from an 1.5 to 3-hour visit. So you can only get so many of those in a day to see patients. We've now dramatically improved that we have 4 of us neurodevelopmental specialists here at Children's, Dr. Emrick practicing at Marshall, and we recently had another developmental behavioral pediatrician who has joined us up here at WVU Children's. So again, not enough yet, but we are working in that direction in recruitment. And so it's been slow and steady in trying to improve that, but it doesn't help, for instance, the location and access. So we have these pockets of us providers, but it's not easy access for our patients throughout the state everywhere. And when you talk about some of our specialties, there are certain things that we need to see a patient in person for and be able to examine and observe. And there are things then we can do through telemedicine or through telephone calls to help with the transportation and access issues for various areas. And of course, that's just related to our specialty in neurology and developmental pediatrics. When you think about all the other subspecialties, when you talk about individuals with developmental disabilities, they usually are requiring a number of medical services, from pediatric GI to pediatric orthopedics, neurosurgery. I mean, the list goes on, endocrinology, like you mentioned. And so all of those fields are also short on the number of specialists, making the waits longer, and again, located in certain areas, because in most of that area location comes from, we do have certain requirements for our practice to have access to certain tests, to be affiliated with the academic centers. And so that tends to lend to these pockets, just like other large children's hospitals. And so it's, how do we become creative and really, one, in the midst of while we're trying to grow and expand and recruit further providers, be able to extend our services throughout the state. And that's what we've been working with partners to do. And I think part of that is continuing to reach out and potentially offer trainings for our primary care providers, so they're more comfortable in dealing with some of the issues that a patient may not need to travel up and see us in person for, or could just be discussed with us over the phone so we could advise the local providers. This is actually something new that we're piloting through WVU Children's, is these kind of physician to physician consults for outpatient visits. And so we can then advise those local providers to kind of assist with their initial workup or initial treatment to get things going, so there isn't that delay in services or starting therapies as well. And I'll let others add to that.
I would say, on the note, I guess maybe I'll explain how we ended up out of state. Because I think one of the issues is we need to have more contracts with several of the children's hospitals in surrounding states. So we ended up out of state. We started all in state, and we just hit a point where our specialists were so far apart and the scheduling issues were so hard. It ended up being easier for us to travel one day to Philadelphia, see all of our specialists over the next 1 to 2 days, and then travel back for another day from Philadelphia, because everybody was in the same spot. When we go there, our son goes to a cerebral palsy program. We are put in a room, and all of the doctors associate who are a team on the CP team actually come to our room to see us. Now we can see other people who are outside of that team. We also have a doctor who is in charge of our team. And in our case, it's the physiatrist who decides who we need to see and can help us get referrals to other doctors in the same hospital. Part of why we decided to go there is that because their CP program is in the orthopedics department. Neurologically speaking, there is not a whole lot that can be done for CP right now. Most of how it is treated is through physical things. So it was important to us that a physiatrist was going to be in charge of our team and was going to be in charge of most of the treatments that he got or needs. So that was how we ended up out of state. And I think that's how a lot of us end up out of state for these very scheduling, need referral type of issues. We need more contracts with out-of-state providers. In addition, right now, there is a situation where those of us who are going out of state to medical providers, we come home with prescriptions and we are not able to get Medicaid to pay for the copay on those prescriptions because our doctors are not registered with West Virginia Medicaid. And they're not going to register with West Virginia Medicaid because their hospital doesn't have a contract with West Virginia Medicaid. So suddenly, those of us who have been going out of state, we have long-term relationships. You know, right now we have a 13-year relationship with some of our doctors, and we're no longer able to get copays covered by Medicaid, and there are secondary coverage. So I think that's something that could be addressed. We need to look at those types of issues because we're not all I think people think that children's hospitals are the same, and they're not all the same. You know, like I had a friend whose daughter needed a liver transplant. They went to Cincinnati. I had a friend whose son needed a heart transplant. They went to Pittsburgh. Because when you're talking about specialty medical care, it gets that nitty gritty. And for us, one of the important things is that a lot of kids need, with CP, who eventually have hip dislocation, need hip osteotomies. There's actually a study that was recently done, our PT told us about this, that shows that the more experienced a doctor is in performing that surgery, the more successful the outcome of that surgery. When the people we know who've had that surgery performed around here, many of them have had to do each hip separately. Many of them have had to have redos of the surgery because it was not successful. And so it was important to us to be somewhere where the doctors, our doctors did that surgery about once a week. So they had a lot of experience. They had standards of care for that particular procedure. And we need to look at those types of issues, that you want the doctor who's done that surgery, that has, you know, what our doctor describes as the most difficult pediatric orthopedic recovery. You want the doctor who's done that hundreds or thousands of times, not the person who does it maybe once every 5 or 10 years.
Thanks, Allison.
The one thing I'd respond back to that is I completely agree, because the longstanding history is there's not been those services here. The one caution I would give is those services are now here. Actually, one of the pediatric orthopedic surgeons here is nationally renowned, has run Shriners in Chicago in the past, in Raleigh, Indiana Children's, and is very good. And so it's been a change, I think, over the past 10 to 15 years tops, that we are acquiring these services in our state. And so I think when we frame the discussion, we have to think about, yes, there's things like WVU Children's, is, for instance, or Charleston CAMC or Marshall are not doing pediatric transplants, right? And there's things like that. But as we try and grow services in the state, I think we do have to think about continuing to build what is here, but also playing off of some of our colleague children's hospitals and services for those things. For instance, I can kind of add to, so the type of spasticity or cerebral palsy clinic that you're referring to, WVU Children's does have that now, multidisciplinary clinic. It's run by one of our pediatric neurologists, as well as 2 physiatrists, physical medicine and rehab, pediatric specific, one who was trained and I worked with in Pittsburgh years ago, who is down here, and now one who trained in fellowship out of Cincinnati Children's and joined us a year and a half, 2 years ago. And so all of those programs, again, are continuing to build in our state, but I think there needs to be further advocacy to continue to support and help those programs build, so that we will have those things available for someday to say, okay, our patients and families don't have to travel out of the state of West Virginia. They can get that excellent pediatric care here in the state. And honestly, that's why I came back truthfully and put roots here. I'm a West Virginia girl, and I thought it was very important that we push hard, that this isn't acceptable, that we have to travel outside of the state to get this kind of care. These sort of services absolutely should be built here. They should be coordinated. You should see all those specialists that come to your room every day when you're there for the visit for the cerebral palsy clinic or the spasticity clinic, or we have a craniofacial one, and on and on. But that's where it is heading in this direction. And part of it hinges exactly like you're saying. Part of the reason that those outside hospitals or out-of-state children's hospitals aren't covered, they won't get contracts with our state Medicaid because the reimbursement is so minimal for these services that they won't agree to the contracts. I used to send patients that I needed on the ketogenic diet to Hopkins because that was something we didn't have here at the time. And I was able to do that for years up until a few years ago. Again, because they're no longer contracted with the state Medicaid, I can't send patients there for that program, even though we don't offer that here. And so that's been some of the struggles. And so I think a lot of this whether you're talking about care out of state or care in state, of continuing to build these services and enable our current providers in the state to be able to continue to improve. It's all hinging around that reimbursement numbers.
Right. Well, and I think, obviously the fact that these programs exist now, this has to somehow be filtered down to the pediatricians who make these
Right.
referrals in the first place.
Yep.
But for those of us who have been dealing with this for now 13, 14 years, it is,
Right.
those are long-standing relationships that we've had to
Mhm.
build. And so then suddenly to ask us to have to change
Yep.
to someone else, where they know our son, they know what, that's a very difficult ask, for us to have to change that level of, those relationships up.
Thanks, Allison. Dr. Emrick, were you wanting to chime in?
Yeah, and I think that, as we build these things, hopefully other families won't have to start out of state, and they'll be able to build those relationships in state, I think might be what Dr. Lindsey was saying. We wouldn't want you to change the providers that you're comfortable with, certainly. I think one way, one of the things is it can be difficult to recruit providers. So for example, Dr. Lindsey mentioned, until a couple of months ago, I was the only developmental behavioral pediatrician in the state and had been for 8 years. So, it took a long time to recruit another one. And so we've tried to send some of our own residents, like Dr. Lindsey, I'm a homegrown West Virginia girl too. So I wanted to come back and help our state for, this need that we had, that was a kind of a gaping hole that we had. So we're trying, we try to send some of our trainees to go and come back from fellowships and things like that. And from a policy standpoint, we might need to look into things like loan forgiveness or other things that could come through the state for pediatric subspecialties. I think that would help. Most of the pediatric subspecialties, aside from hospitals medicine, are at least 3-year programs. And so sometimes that's a big ask to get a resident to do an extra 3 years of training when they were still making, like a much smaller salary than what people think of as a doctor's salary, when they have such insurmountable loans. So that might be, from a policy standpoint, something that could help with recruitment to our state. We want to have those hospital support systems to kind of back up the subspecialists as well. So it's kind of making a commitment to supporting those programs and those providers.
That's a great point, Dr. Emrick. Steve?
Hi, well, taking great notes, just like the audience out there, I'm sure, because this has been a great discussion just so far, and we're just halfway through. The issues that we hear have been reflected in the ones Allison and Christy and others have brought up, and Bill brought up from one of these staff people so often. And people just have a comfort zone with going to Columbus or Pittsburgh or, wherever, because of the multidisciplinary, et cetera, and the history. Like Beth was saying, once you've got that established, it'd be kind of hard to break that, And I've really been very encouraged and very excited about what Dr. Lindsey's been talking about in terms of the capacity building here in our state. As an advocate, I want to make sure that people are not going where it's just maybe to a referral advantage. Not to point fingers, but we know that there is some kind of home cooking that goes on too, which is only possible, is only practical, that people are going to speak to what they know about, or maybe what's in their system. We're going to try to help parents, families to access what they need if it is out of state, even if we have some capacity here, it may not be the one that they need, so forth. I just put that out there. But we need to be, as advocates particularly, and there's many, many advocates and allies on this call, more knowledgeable about what is going on. I think just the things that Dr. Lindsey was outlining and Beth has talked about have been very encouraging. But for us to be effective, I think, in helping families, it's going to be important for us to keep up with the developments about the capacity and what's possible there. So that's just a wake-up call to me and to others in that position. Just wanted to throw in, not to prolong the discussion necessarily, but just to throw in that we still hear from a lot of families about accessing dental care, and it doesn't even have to be specialty dental care, but the issues involved with simple procedures to most people. I think Allison was pointing out some of that. Christy points that out a lot about just, things that when you're it may be the sensory issues that are affecting the problem. It could be just aversion to pain like we all have, but it could be really, outscaled. So there's a lot of yet work to be done in getting more people accessing dental care. Dentists around, probably, we have a lot of dentists in the state, probably not enough, but we do have. And we need to figure out more ways to work with dentists to do that. My dentist said, I take people on Medicaid, but Medicare, he said, I'll serve them for free rather than to go through that. So, there's all kinds of hidden barriers that might exist that I wasn't even thinking about, of course. So with that, thank you very much for that rich discussion so far.
Yeah, Steve, actually on the dental note, one of the issues that a lot of people with wheelchairs have is, again, the accessibility of equipment at a dentist's office. Our son has never been able to take the 360-degree x-rays because he would have to sit in his wheelchair for that, and that the equipment is not made to go around a wheelchair. So there are some just equipment issues relating to dental services around here. And I go back to, if there's someone who has this equipment, we're not aware of it.
Thank you, Allison. I'm going to turn to a question in the Q&A box before we move on to the next question, and take any closing thoughts you may have on this question from panelists. I want to acknowledge that Delegate Danielle Walker is with us today. Thank you so much for joining us, Danielle. And this is a comment and question from Emily. Speaking to Allison's point, my son will be 4 in December. At 4 months, he was seen at Women and Children's in Charleston for a seizure disorder. The long and short of it is that we were told his case was too complex and were sent back to Cincinnati. I was not aware of the program at WVU Children's, nor was I advised by the physician we were seeing at Women and Children's. With many programs in the state, there seems to be an issue in getting this information out. This seems to go back to physicians and hospitals within the state not collaborating in a way that benefits parents and caregivers. While there may be an interdisciplinary team at WVU, what about collaborations between CAMC, WVU, CABEL, and everywhere in between? Is anything being done to address this?
So I can start with that. So there have been collaborations between WVU Medicine and Morgantown and our other health systems and CAMC. The collaboration is through the medical school there, but CAMC is not part of the WVU Medicine hospital system per se. And their children's hospital and staff, as Beth can speak to it as she was previous faculty there, the majority of their pediatric faculty is well aware of our programs up at WVU Children's. Now, whether those providers choose to refer to us and make that known to families, that's been another difficulty to navigate. One of the things that WVU Children's is making a large push now that our service lines have grown significantly in all specialties, not just pediatric neurology, is better marketing. That they've actually hired folks through marketing that go around and meet with primary care providers that are in outpatient clinics and discuss with them lists. And they've even taken the past 3 new faculty. So I'm now in the past 2 months in charge of our pediatric neurology division as well. And so they've actually taken our new faculty around who have various subspecialties. So for instance, we now have a pediatric neuroimmunology MS multiple sclerosis specialist, which this state has never had. And it's a brand new program. And we actually have a clinical trial we're starting looking at MS medications in pediatric patients and studying that head to head. That is something that, again, has never even remotely occurred here. Now, the problem is we have to let others know about that, because in the past, because we've not had that particular specialty, and it is super specialized, like you refer to about some of the other care, those patients have gone to Cincinnati Children's, they've gone to Pittsburgh, they've gone to Hopkins, they've gone to CHOP, right, in the meantime. And so they're not going to switch care. They're established, right, with their providers. But the new patients who need evaluated and diagnosed, we can now provide those services here and even offer, you know, state-of-the-art clinical trials in these cases. And we're doing that in multiple areas, but it's getting that word out. In regards to WVU Children's and Marshall and Hoops Children, actually it was announced, Lesley could probably give better timing, but I think it was probably about 6 to 8 months ago, a collaboration that is between our two hospitals. And so we are sharing patients' information, subspecialists. So for instance, we have a neonatal physician who also specializes in neonatal genetics. So she's doing specialty consults for the NICU down at Marshall. And so we're going back and forth in that case. So previously, Marshall, for instance, would refer a lot of patients to Cincinnati based on the location. And so now they're trying to share those programs between the two. So those things are in the works, but it is obviously getting out to everyone. It has been difficult.
I think there's, go ahead, Dr. Emrick.
I was just going to say there is a West Virginia Children's Hospital collaborative group that meets periodically that includes hospital administrators from the 3 children's hospitals, as well as the chairman of and chairwoman of the pediatric departments. And some of the subspecialists have attended those meetings from time to time. I haven't, so I don't know exactly what they do, but I know that they talk about some of those issues. I think one really important thing to do is, you know, just perhaps to our list from the American Academy of Pediatrics, we want to make sure our family practice docs who care for children know, but just, you know, here's the list of things that are available, and try to update those as new services come online.
Yeah, I think there's no doubt that at times there are, you know, there's the practice of medicine, and then there's what I'll call the business of medicine. And that there can be competition. You know, when Andrew was shortly after he was born, we were told after the newborn screening that he was probably going to have some hearing issues. And so we had an ENT appointment scheduled here in Charleston, and they could not perform the ABR here. So they made an appointment for us in Morgantown. Well, as it turned out, Dr. Tuma's office in Huntington had ABR equipment, and they were able to perform it. And he was like, why didn't they just refer you here? Well, and I think at the heart of it was that if we went to WVU, we were going to end up back at their doctor's office. But if we went to Dr. Tuma, and, you know, him being, you know, only an hour away, then we were probably going to end up there. And that is, in fact, what happened. We ended up, you know, seeing Dr. Tuma and continuing on there. But in the back of my mind, as this was going on, I really felt that was probably a decision, you know, where we were going to have to wait 6 months for an ABR versus a month. I felt like that was a decision that was made in the doctor's interest and not really in Andrew's interest. Because we needed to have that test done as quickly as possible. So you guys can just take that information for what it's worth.
Thank you, Allison. I want to mention a question from Delegate Walker. Is the website of specialty clinics or physicians available to families? Would this be helpful? And what is your go-to resource center for families with a new diagnosis?
I can't speak to where the list is housed for the Association of the Children's Hospitals. I have not seen that personally. And if they're keeping that up to date, to my knowledge, I'm not sure how often they are meeting between those groups to update that. Obviously, I can speak to the health system that I'm part of, and WVU Children's is actually continuously revamping. Actually, we're part of with a new opening in February of our new children's hospital, completely revamping the hospital website. And so there are pages specific for each subspecialty, and it is available now that you can go to, and you basically, it's just alphabetical. You pick the letter, it brings up the program, it gives you the information of how to call the office number for referral, what providers are listed. I'm in the works, particularly for neuro, to answer the second part of the question of within that subspecialty, we have pages for each of those multidisciplinary clinics. And within that, previously, it was just information of what the clinic basically was about and the providers. I am now, with the new opening, having them add in our diagnoses that we see, and then clinical educational information links from each of those diagnoses, and then also resources for national groups, support groups for families, so quick links for all of that. So it's kind of a one-stop, easy education that families can access whether they're seeing us or not. They can just go to the website and access that information. And that's stemming from some of what we did here with the Neurodevelopmental Center of what we offer resource-based for families, but being able to keep an online, live, updated version of that, that's quick and easy access for families, again, whether they're seeing one of our providers or not.
I think a solution would be to somewhere have that list for all providers within the state, just because, you know, I live in Cabell County. So it is much closer for me to go to Columbus or Cincinnati than it is to Morgantown. You know, and there's a lot to be said about even just traveling. You know, an hour and a half with a child with a disability is much easier than 3 hours, you know, half the time. But I do think that we need some type of comprehensive list or that medical home concept or you know, someplace where this is accessible to all families. So all families can make the choice of the best provider for their child. And just like, you know, I think Allison said she went to a cerebral palsy clinic in Philadelphia. Several of the larger children's hospitals have Down syndrome clinics, but there's not a Down syndrome clinic in West Virginia. And I can tell you, even while we might have a specialist in West Virginia, a pediatric specialist, that doesn't mean that they see that many children with Down syndrome. And, you know, I know that my daughter has her own, some of her medical conditions or issues that she has is, you know, they're a specialty in themselves. So I think that there needs to be some type of portal or the whole medical home concept, or, you know, where everything is housed, or where there's a team, that comprehensive team, even if it's in a pediatrician's office, to where everybody knows what's going on. And I think I might be jumping ahead of the game here, Kelly. But
Christy, I actually want to you know, tail what you're saying here. I do think a website with all this information is very important, but I think one of the things we have to understand too is how parents go about finding care, and that is through referrals. And we actually get a lot of information on Facebook from support groups with other parents who's had this. Like, for example, I mean, I've mentioned we go to the CP program at CHOP. I said, but if Andrew ever needed a selective dorsal rhizotomy, the best doctor to do that is Dr. Parks in St. Louis. and I know this because I've seen this through all of our support groups of people who have had that. And I think we are shopping for such specialized care in some instances that it starts, like Christy said, becoming more important, like with the hip osteotomies. How many have you done? What is your success rate? You know, those types of things, as opposed to just seeing that, you know, somebody has a CP clinic. What is great about your CP clinic? why should I choose your CP clinic over someone else's? And it really starts getting into the nitty gritty about that.
Yeah, a matter of fact, it's funny. This morning, I've already received a message from a parent about a specialist. Who does a parent of a child with Down syndrome? Who does your child see for this? Do you like them? Do they, and you're right. That is where a lot of people get, other families get referrals, I think, from experiences and similar experiences.
And just a quick comment about the need for a list or a website. I mean, I would echo what Christy had mentioned earlier, but also if the list could somehow designate which providers are Medicaid eligible, I think that West Virginia Medicaid eligible would be a huge benefit.
That's a great point. These are all great points, and it really segues into, and you may have answered the next question. Many of the challenges families face come from the same root problem, communication. So how do we improve communication between provider systems and most importantly with families? Some of us were talking yesterday about, how it changes the trajectory of treatment for a child, that how the diagnosis is handled, and then, how kind of resources are available. And I work with a lot of families who do a lot of Googling or looking for information. And we talk in different circles about misinformation and how, you need to find a trusted source of news. But where do you find that if that's not readily available for you when you've had, rather frightening diagnoses and you're really in need of help?
I think in talking about communication, I think we have touched a lot on that issue, but, I think it all goes back around to the importance of community of continuity of care. I know and it's the same thing that we were just talking about. All of my daughter's doctors are not in the same network. They all ask, when we go to any doctor, they ask us for our daughter's pediatrician, but, the records don't always make it there. So, that's another hat that parents have to wear. Is that of case manager. I learned early on to get Gracie's records, from hospital to hospital. And then I keep a copy. It's funny, I have a tote full of education stuff, and I have binders full of medical results and information. But, it's just like lab work. If it's not if that physician doesn't have those results, guess who gets another lab stick? Gracie does. And it's traumatic. She's quite the trooper these days, but it was really traumatic when she was younger, and when she had a lot more going on than what she already does. I mean, she has 7 doctors, and she has since she was 3. So managing that in itself is difficult. But and then it goes back to insurance. If you repeat that test, it doesn't necessarily pay for it. So now you have an extra bill. So it goes back to continuity. As far as communication, also, I think you might have just mentioned this too, I'm constantly giving Gracie's medical history, but I'm not a medical professional. What if I misinterpret something? What if I forget something out that's important? Mistakes can be made all because there's no communication. So again, I think that we need to look at the medical home. I think that with communication, we also, I wonder about portals. Everybody has portals now, but no, the portals are not connected all together. So I might be able to get some lab work off of a portal to give to the next doctor. But again, I'm wondering if there's not some way that portals can be connected together. If it's through social security numbers, I think pharmacies are linked to different portals so that they know who got what prescription. You know, you can't go to two different pharmacies to get a same prescription from two doctors. I don't understand why we can't have some type of universal portal. I think that would help a lot with communication. I also think that would help a lot with different doctors out of different networks to know what is going on. I think that it would also, you know, I think it would help all the way around as far as that, and having those teams, and even if that's not by the pediatrician. But I, you know, again, I just, communication is a huge issue, and it does cause a lot of frustration. I know it took me 3 months to get a referral, and it was really all about communication.
Yeah, this is actually my binder that I carry around that has medical information, and this just happens to be what we have in here at the moment. We have other records here as well, but that's what goes around. And, you know, when I get a note from the doctor, I put it in there. The other thing I guess I would add, this week, it was brought to my attention when we were getting blood work done at CMC that because my son is 13 now, we're going to have more difficulty accessing his electronic records at CAMC. And I don't have this issue in Philadelphia, so I'm guessing that this is a state issue that somehow, or a CMC, but possibly a state issue, that because he's now 13, I can't access it, you know, and him as, you know, with his medical conditions, he's not ever going to be able to access his own electronic records. And it seems to me that there should be a way that we should be able to overcome that. You know, that given his medical conditions, that we should have access to his electronic records between now and age 18, you know, until we apply for guardianship. Because it's just one more step if we have to physically go get his records, as opposed to us being able to pull them up on CAMC's electronic system.
That's a great point.
So
Sorry, go
I'm
ahead.
sorry. So to speak to both of those, the first one about the records, that actually is supposed to be a national law that starts at 13, but there is ways to access it. It's another extra step, unfortunately, for parents to do, but there is a form that can be signed off on. Usually it requires one of his providers to sign off on that as well, that you get access. And if the patient has the ability, for them to sign off for allowing you to do it, typically. But there is a way that you could do that, and then you have access or proxy to his electronic chart. So technically that should be occurring at CHOP as well. And I don't know if that just hasn't come up with the visit, but that should be across the board at any medical facility when he's 13. But again, not making it easier for our parents caring with patients that have developmental disabilities, right? And then the second piece is kind of that systems or portals being linked. That does occur to some level. It depends on, for instance, if you're talking about like your child's going to Nationwide, or your child's going to CHOP, or your child's going to Cincinnati, and maybe a combination of both, depending on the specialist, right, or the specialty care you're looking at. I can say that all three of those systems plus our system use the same electronic medical record system, which is called EPIC. And so because of that, there is something available called Care Everywhere. So I can actually, if I'm seeing your child in clinic that day, there's a little button I can push, and it pulls up any facilities that he's been seen at that also has EPIC. And I can get access to test results, like lab results. I unfortunately cannot see images, which is a hard thing in neurology, that I can't see their MRI pictures, but I can at least see the report from the neuroradiologist from that facility. I can also see their clinic visit notes. Now, that being said, there are some children's hospitals who have opted into that, but don't allow full access. So I can talk about kind of my previous training facility, Pittsburgh Children's. They are part of Care Everywhere. But if I'm seeing a patient, I can hit that and see their lab results and their test results, but but I can't see the clinic notes. I can see that they had a visit encounter, but it won't let me open their notes for certain specialties. They have a lock kind of on that. So to what level we can see is a little bit questionable, but most of the children's hospitals have joined in and it's full open so we can see everything. That being said, do all physicians or providers use that and review that? Probably not. Would be the experience I'm sure you guys would remark to. And I think that's really provider specific, unfortunately, right? I wish everybody wanted to review and get that history. For me, that's really important when I see a patient to have that background, because again, I don't want to duplicate tests. I don't want to put my patients through extra things. And I'm trying to add to their care, not worsen it or cause a new problem, right? And so that is available. So one of the things, knowing that at least as parents, right, or guardians of these patients, asking the provider, you know, if they're asking you for information that you may not have, did you check care everywhere? Is that there? Now, there are a few other systems that other hospital systems use. One common one is called Cerner, which again, then that doesn't always cross with Epic. So then it becomes kind of what company is that hospital using? But a large majority of the surrounding children's hospitals use Epic.
But Marshall and CMC use Cerner. So those don't talk to each other. The subspecialist in Charleston previously had Epic and also recently switched to Cerner. So within the state, we do have an issue with that, of being able to see, you know, now that I'm at Marshall, I can't see notes that Dr. Lindsey has written on our common patients, although I could previously when I was in a different system. So I think that's still a barrier. And I think that that's one that ought to be addressed. But from an informatics standpoint, that's probably a little above my expertise of how that would happen.
Thanks, Dr. Emrick. Dr. Cottrell, did you have something you wanted to share?
Only to say, I mean, I was just going to go back to what Christy had mentioned, which we get to later, the medical home. And I wanted to say the same things that are being discussed here could be copied for other providers for that family, right? So I didn't want to move to another topic without, you know, the focus here is on medical providers, but there are a lot of providers, there are a lot of services being provided for the family that aren't coordinated back to the medical provider either, and vice versa. You know, home visiting, other program, you know, it's same things that are coming up are happening across the board. So just everything that we've heard from Christy and Allison times that by the number of providers, and that's challenging. So whatever solutions are there, it would be great if they incorporated outside of the medical piece as well. That's all I wanted to say.
That's a great point. Thank you for sharing that. I want to add a comment from Delegate Walker and then get to our next question. From Delegate Walker, with the recent loss of my oldest son, is there any education for parents about end-of-life care such as advance directive, living will? Is there a clinic for wills as many as primary care, as primary health care givers? My youngest has autism. I was dependent that my oldest son would care for his brother. I'm at a roadblock because my youngest son is 20 years young. It's pain and paperwork. What are the resources?
I would say we, along with others, hear questions similar to this. Maybe not all the particular points that the delegate mentioned, but one is getting advice about seeking wills, trusts, and those types of legal documents. We just an FYI, we don't give out for fear of maybe advertising for certain providers, certain attorneys, for example, and not others. We're very cautious about how we handle that, so people might get frustrated with us. We did have an attorney from one big firm to address the questions around estates, trusts, wills. A few years ago, we still have some of that available on our website. That may not be adequate, but we do have a pretty good overview of how to help families and just lay people in general be able to work with an attorney in that regard. And we also find that generally speaking, special needs trusts, for example, are, we think, best handled by typically larger firms that have people who are specialized in those areas rather than just anybody. And a lot of, we hear stories about people having very poorly constructed special needs trusts because the person, the attorney went to just wasn't equipped for it. We really feel like this is a specialty area in itself. And now with the West Virginia ABLE program, that is really a big factor and would be something that people would need to use to understand and to use the West Virginia ABLE program through the Treasurer's office and in respect to how they craft those special needs trusts. It's not to exclude special needs trusts, but it's just a combination. To the questions about end of life, we probably don't have a lot of advice on those areas. We do. We have a lot of opinions, but I'm not really going to share those this morning about some of the bad, what we consider bad policy, but will be on the scope here maybe.
Thank you, Steve.
I can say as a parent, I don't have any resources, I guess, to give, but as a parent, I think I think about it in some of my experiences with my daughter. And I think it makes me nervous, the whole subject, because what I have found and what I've heard from others is that sometimes because our children do have developmental disabilities, there's a judgment on quality and what is quality. So I just wanted to put that out there. So when we, talking about advanced directives or making those decisions about living wills or that sort of thing, I think that sometimes we're quick to or not maybe we, but sometimes healthcare professionals do make quick judgments about that issue.
Thanks, Christy. I'm gonna segue. We have about 12 minutes left, so I'm going to segue to a next question that we had discussed yesterday, and it's rather timely, perhaps, and a good segue from the last discussion. This is the last question about communication, which is an ongoing problem. We've read in the news from other states such as Kansas and Alabama, where access to life-saving treatment for COVID-19, such as the use of ventilators, could be restricted. Alabama public health protocols currently list severe and profound mental retardation and brain injury as among potential reasons to be denied a ventilator in a crisis. These protocols include children. There are legal and ethical challenges to this, and we've not read of any such protocols in West Virginia, but we want to open the question up for discussion. Do you think it's a valid concern that medical professionals could make a value judgment that the lives of people with developmental disabilities could be less worthy of life-saving care during the pandemic? Would anyone like to?
I think it is a valid concern. And one of the things that I have had to come to understand, I often say that Andrew's disabilities have brought out the best and the worst in my character. And, I think when my husband and I had Andrew, we always thought, oh gosh, he'll grow up to be an attorney just like the two of us, or, and of course that didn't happen. And I think that one of the things I sort of had to come to terms with is that you can have a good life regardless of what your profession is, and that we do have to be very careful. You know, I guess it's not unusual to hear about circumstances in which someone, you know, becomes disabled later in life and they can no longer do the things that they once did, you know, like maybe hike or climb mountains or whatever. And so you know, I am not a big, I mean, we do hike occasionally, but I'm not like, you know, I've never climbed Mount Everest or anything like that. I still have a good life. And that people with disabilities can still have a good life, even though they may not do some of the things that you know, typical people do. So I do think we have to be very careful about passing judgment. We have always had a house that has been open to providers bringing in students and things like that, especially when Andrew was in birth to 3. And I remember one time a resident came to our house, and when she was told that Andrew had cerebral palsy, she started asking questions about, well, how long is his life expectancy? And the provider was trying to explain, you know, no, CP doesn't necessarily affect life expectancy. It can cause secondary conditions, associated conditions, if you have more severe forms of CP, such as pneumonia or, you know, certain infections because of feeding tubes or things like that, that those things can affect how long a particular person lives, but CP as a whole does not affect life expectancy. And so right there, we had, you know, someone who was a doctor who was making a judgment on how long our son might be able to live when he had a condition that doesn't really affect life expectancy. So I think it is something we do have to pay attention to.
Thanks, Allison. Pam?
Yeah, I think that's it's an important point for me. Just having that conversation yesterday helped me think that, you know, we just need to make sure that we're providing opportunities for the professionals who are working with families to have that sort of knowledge so that they're prepared to support families, so families know, you know, long-term, not what they can expect for their child, but that they can support their child long-term. And so they're prepared for those kinds of questions. You know, we probably need to do some intentional, we do some already, but some intentional professional development to help them think about that. And I'm glad, Allison, that your, you know, therapist, whoever was there with that person, was helping them understand the situation. So we just want to be prepared to do that.
You know, Pam, on that note, the doctor who told us that Andrew's prognosis was that he would never walk. The way she said it, and I have so appreciated the way she said this, she told us that we needed to understand. She said, I never say never when it comes to kids because they sometimes surprise me. She said, but you need to understand, he was 2.5 at this point, that medical science is not on his side. She said, you need to envision your life as one with equipment. She said, you can go do the things you wanted to do. If you want to go to the Grand Canyon, you can go to the Grand Canyon, but you need to envision that trip as one with equipment. And that made a huge difference in terms of how we moved forward, because we started envisioning our life as one in which we would be taking equipment around.
Thanks, Allison. Steve?
Yeah, I would like to just, I know we're really tight now, This is such a critical issue, and it has certainly been brought to the forefront over the last 2 years because of the pandemic, particularly. Grave concerns across the nation and around the world, I'm sure, about the whole issue about the value that is placed on people with disabilities of all types. And this obviously includes children with developmental disabilities and particularly people with severe disabilities. And it's really caused a lot of energy around the country. And here in the state, I know we as an advocate agency have joined with other advocacy agencies and expressed grave concerns to the policy directors in our state, lawmakers, as well as the governor and people at Department of Health and Human Resources, for example, about a cautionary note and a plain out statement: do not ration care to people because of your notion of the quality of their life. And there's a lot written on it, a lot of, I consider pseudoscience, but there's a lot of charts and forms and graphs and tests to decide what the quality of a person's life is. And we think that's hogwash, basically. And that is really not applicable to human beings. It might be nice for other purposes, but not people. And so we've hold firm, and we I think join with our other advocate allies of people across the state in saying this is unacceptable. There's other means of doing that, and triaging service and so forth. And there are large biases that are ingrained through our culture in general, not something you learn in school, something that you learn from growing up, I think, and just living in our society. But it's a huge topic. We said yesterday this was a whole workshop and discussion item of its own that we really would like to have. So that's just a few words from the Developmental Disabilities Council.
Thank you. That was really important to share. I appreciate that. We have about 3 minutes left, and we only got to a handful of questions. And so I want to say to the panelists and to anyone watching as well, are there any last comments, ideas, or recommendations that panelists or those watching would like to share before we wrap up? Is there anything that we missed, or any priorities that you want to make sure we get on record, or ideas that perhaps this project should focus on as we move forward?
One of the things I just wanted to stress kind of plays off what Dr. Cottrell brought up earlier. When we're kind of talking about specifically working with better reimbursement for providers and DME, when we're talking about providers, that should also include, when we're talking about legislation, not just the medical doctor's visits or seeing the nurse practitioner. That includes therapists, those in-home nursing visits, home nursing, better reimbursement, because even when we sometimes are able to cover with insurance, we no longer have providers to give those therapy services or those in-home nursing services that are needed. And that's because our state is just lacking in actual those therapists and providers. And it stems a long time from not being able to build, like you said, a business around it that's sustainable for a lot of these folks. And so even when medically recommended, prescribed, folks are still not able to get the services they need. And so I think that's really important, that needs to be included when we talk about policy making and working on better reimbursement and recruitment for these services.
I also think we need to look at, and I'm kind of going to tail off of Dr. Lindsey here. And from birth to 3, providers, therapists come to your house. And it's a wonderful service that you appreciate even more once your child has aged out of the program. I'll say that with our son in particular, because of his physical disabilities, it would be really great if we could look at some ways of having, and I don't even mean necessarily every visit, but having some more home visits, so that our therapist can work with us like on his equipment. You can't just haul a standard to the clinic. And I certainly can't just haul a standard to the clinic with my son in his wheelchair in our car all at the same time. So it would be really great if we could get visits so that, like, for example, our PT and OT could come to the house and look at what we have. Do we need to make adjustments for his growth? Do we need to do some of those? Do we need more equipment? Is our, shower chair not working for us anymore? Let's look at the setup that you have and figure out what you need to work, in your house specifically. And it would be really nice if we could get an extension of those types of services in our house, at least from time to time, so that we can learn things like how to better change our son when we change his clothes or his medical briefs, because that we really need our home to where most of this happens to be the place where they're showing us how to do these things.
Great point. Thank you.
I'm actually so glad you said that, Allison. Just as a quick, that's been kind of my dream plan that I've laid out and been trying to map out for about 5 years, that we have the pediatric resources throughout the state, and there's hubs, and then they go into the home providing those services. Obviously, COVID put a halt on everything in trying to push that. But starting kind of at the ground roots is we need enough providers to be able to start those kind of projects. And that's where that push for any sort of legislation to help us with recruitment and from reimbursement to really start to provide those services. But I wholeheartedly think that's where we need to be providing those services.
Thanks, Dr. Lindsey. Dr. Cottrell?
I just want to mention, I think it's great, the nature of the panel here to have family and providers of different types. And I think that, part of the thing that we wanted to talk about here and ran out of time was communication and getting that input. I think the family stories, the family experiences are key for the providers to hear. And I'm not just talking about medical providers, across the board to hear, so that if there's an issue with the regimen or treatment of care that's prescribed, if there's an issue that it won't work when they get home, it's good to know and modify it on the cuff. So this hub and spoke system also gets everyone together in the setting where it's going to happen. And just wanted to mention that the stories are rich and need to be part of that treatment. And I can't wait until COVID's gone and Dr. Lindsey's model gets put into place so we can see it.
Well, thank you so much. And I'm glad that we're kind of ending on an optimistic note today. And I'm sorry that we didn't get to all the questions that we had, and hopefully we can do more of this kind of streaming dialogue in future months. I would like to really thank the panelists for joining us today. Thank delegates Walker and Pushkin for joining us, to Amanda and Ashley in the Q&A box for their kind words, and everyone else who joined in with thoughts and questions. And many thanks to the West Virginia Developmental Disabilities Council for funding this important project. We hope to see you on social media to keep the conversation going, and we will have this video posted tomorrow on YouTube. And as I mentioned before, we'll be writing an issue brief detailing the challenges and recommendations made during today's event, and we'll be sharing highlights of the project and on this discussion on Facebook and social media. Until then, we hope you'll get more active in the project, to join our email list, and get involved as things evolve. So again, thank you, everyone, and I hope you have a great day. Bye-bye.